Okay, everyone, welcome. Welcome to the Alliance of Private Special Education Schools virtual conference series. My name is Joanne DeSimone, and I will be hosting tonight's session. This is the second conference of three scheduled for the 2024-2025 school year. A couple of housekeeping notes. Please remain muted for the duration of the webinar. All questions can go directly into the chat, and we'll get to as many as possible at the end of the presentation. Before I introduce Dr. Michael Selbst, please enjoy this video about the Alliance. My job at the Alliance is the outreach coordinator. I also am the Alliance's advocate for parents. There's several things that I do. One is I make referrals, school referrals to parents. The other thing I do is I make sure that parents understand what their rights are in special education. We are also here as a resource to districts to help them find appropriate placements when they are struggling to meet the needs of their students.
The Alliance mission in general is to make sure that all students are in the appropriate place and to help them with whatever it is that they need. It's really about the child. We started programs. So every year we have a conference. This year is a little tough because of the situation, the COVID. So, but in every other year, we've had a conference where we've provided information that's helpful, things on transition, other programs of what's available to students and how they can transition, whether it be from middle school to high school to college, high school to trade school, or whether to work or whatever the next step is for them.
When a parent calls, I'm the one who answers the phone. Whatever information they want to give me, I'm there to listen. I'm there to help them digest their situation, to brainstorm with them, and to help them reach their goal of finding an appropriate education, an appropriate school to meet their child's needs.
We've also give out scholarships every year. We give scholarships not only to the children in our schools, but we've actually given out scholarships to special ed students in the public schools.
One of my favorite things on the Alliance's website is the school finder. They can go right on the website, and we have the school finder will list some options, the type of disability a child has, the age range. You could even put the county that you're coming from, and it'll give you a list of schools that meet that criteria. And on our website, there's direct links to all of the schools. So then you can easily make your list, take a look at the websites. And, you know, when parents call me, I always say, listen, you take a look at the websites, and then call me if you want more specific information. COVID has created all kinds of havoc, and educationally, you know, for months we can see how difficult this has been on the special education students.
We're a little bit of a smaller environment. Our schools are a little bit smaller, so we kind of have an advantage.
When you have just 70 students in a building, it's much easier to control your environment, you know, and much easier to offer in-person and hybrid models right away. Special education is complicated. You know, I was a special education teacher, and I remember when my son got diagnosed, I was lost, me. And I remember the first thought I was having was, okay, I'm in the field, I know who to call, I understand the terminology, I get the process. What are parents doing when they don't have a master's degree in special education?
We want to make sure that parents have everything at the disposal that they need. Because again, our goal is always about the children and where the children belong and how to educate them to the best and to their highest level.
And now I'm thrilled to introduce our speaker for this evening.
Dr. Michael Selbst is the Executive Director of Behavior Therapy Associates in Somerset, New Jersey. He's a licensed psychologist in New Jersey and Pennsylvania, certified school psychologist, and board-certified behavior analyst at the doctoral level. Dr. Selbst earned his undergraduate degree with honors in psychology at the University of Delaware, and he was awarded a university fellowship to Temple University, where he attained his master's in education and Ph.D. in school psychology. He has expertise in the evaluation and treatment of clients who present with symptoms of anxiety, depression, ADHD, autism spectrum disorder, Asperger's syndrome, obsessive compulsive disorder, mood disorders, oppositional defiant disorder, social skills deficits, learning disabilities, as well as family and relationship issues, parent training, and co-parenting. Dr. Selbst has extensive experience working with preschool-age children through adults, including expertise helping individuals working through significant life changes and transitions. He has led numerous workshops, including at local, statewide, national, and international conferences. Dr. Selbst is co-author of the Behavior Problems Resource Kit, Forms and Procedures for Identification, Measurement, and Intervention, and the Social Skills Curriculum Power Solving, Stepping Stones to Solving Life's Everyday Social Problems, and the book chapter Acceptance and Commitment Therapy in A.G. Dempsey's book Pediatric Health Conditions in Schools, a clinician's guide for working with children and families and educators. Dr. Selbst, we're honored to have you with us tonight.
Thank you so much. It's really an honor to have the opportunity to present. I'm going to get the PowerPoint up and going here. If you didn't notice in the chat, let me just bring it to your attention. So the PowerPoint will be available for everybody on the Alliance website right after the webinar. You see my contact information here. Obviously, that'll be on the PowerPoint. So everything you see here will be what you'll have an opportunity to receive. And again, this webinar is being recorded. In the chat, you'll have the opportunity to ask questions, provide comments, and somewhere about 8:15 or so, we'll take a look at those questions and comments and have a bit of time until 8:30 to do my best to answer those. So we appreciate any participation that you might have. And if you think of some additional questions or comments, concerns after the webinar, feel free to email me. That's really the best way to contact me. So it's, again, my pleasure to speak. In addition to the background that you just heard, I am the Executive Director of Behavior Therapy Associates, which is the group private practice, and we provide school-based consultation as well as professional development throughout the state and beyond, as well as direct service, individual therapy, family therapy, social skills groups, parent training for children through adults. I'm delighted to talk about this topic for a number of reasons. It's increasingly become a very hot topic, not just in the New Jersey area, but across the country and across the world, as you'll hear as I'm describing this. I want to emphasize from the get-go that pathological demand avoidance, or PDA, is not a diagnosis yet in the United States. We'll talk more about that. It's not in the DSM-5. What will happen in the future remains to be seen, but I just want to make sure that we're mindful of that as we go through. And additionally, as kind of a disclaimer, I want us to be mindful that what guides us in terms of treatment is what evidence-based practices would tell us, and we know that applied behavioral analysis is scientifically proven to assist individuals that present with autism spectrum disorder and a variety of other significant behavioral issues. So, and not just thinking about ABA, but we want to fall on what guides us in terms of behavioral change and social emotional learning, mental health intervention, that whatever it is that we're going to do to try to help, whether it's children, adolescent, or adult, make sure that it is evidence-based that is guiding us. So here's my ambitious agenda. I hope that we'll be able to get through all of this, and if not, you'll at least have the content. I can't always guarantee what my pacing is, but this is my anticipation. Perhaps some of the vignettes we won't get through in complete detail. So we'll talk a bit about what PDA is and what it isn't. What are some of the core characteristics that we need to be mindful of? What are the challenges for an individual who presents with PDA symptoms? What are the factors that contribute to that presentation? What does the research tell us? I'll give you a little bit of a hint. There's not a lot of research, at least not yet. Talk about diagnosing PDA, and gave you a little bit of heads up on that as well. How does PDA compare to oppositional defiant disorder, or ODD? Is it the same? Are there overlapping presentations? We'll talk about compassionate care and how critical it is to be mindful of the individual and the family and educators and mental health providers in terms of our understanding and treatment for individuals who present with these symptomology. We'll talk about educational and behavioral supports that are relevant. How do we support families as well as educators? And again, some vignettes, some examples of helping us to increase our understanding of PDA. So if we were kind of a live audience, interactive throughout this, I might ask you, when you first heard of PDA, what were you thinking? Or, jokingly, would we say public displays of affection? That's typically what we think of as PDA, right? Well, pathological demand avoidance, unfortunately, is a far cry from public displays of affection. Although I guess we could argue that it's really representative of how the individual may present their emotions. So maybe that's the only connection. But what we want to be really clear about from the get-go is that PDA is a behavior profile. It's not a diagnosis. And there's really a difference when we're trying to identify and look at profiles compared to diagnosis. So since PDA is not in the DSM-5 or the ICD, which International Classification, diseases, 11th edition, we cannot give a diagnosis yet. So if you're describing your child and say, well, my child has PDA or my child is diagnosed with PDA, that would not be the case. We cannot describe our child as having PDA or having a diagnosis of PDA, but we might say that the child presents with a profile of symptoms that seem to align with PDA. That's sort of a lot of language, isn't it? But the takeaway we really want to have from tonight's webinar is to expand our understanding of what a PDA presentation looks like, rather than say my child has this per se, or my child or this adult has PDA, but presents with some of the symptomology that the field is describing associated with PDA. And additionally, with the understanding of what the PDA profile is that we want to strengthen our understanding of how to provide interventions. And while we have to be mindful that because the research is really at an infancy stage, the evidence-based treatment for specifically PDA is also in its infancy stage, which means we have to call on what we know about similar kinds of presenting issues. That's a bit challenging because, again, this is a profile which is relatively new. So research new, hard to say, here is for sure exactly what will work. Yet what we want to be open to is the importance of compassionate care, greater understanding and appreciation, how components such as heightened level of anxiety and heightened arousal level really impact the individual, and what we need to be more mindful about when we're working with that individual. We do know that the profile is commonly associated with individuals with autism, and thus far, that's probably the greatest correlation, that individuals with an autism spectrum disorder are the ones more often that we're seeing this profile of PDA. Although it's also associated with individuals who have ADHD, oppositional defiant disorder, and some history of trauma, such as post-traumatic stress disorder. So not uncommon in the field. In fact, where we see comorbidity, and as we're talking about a profile, what we want to understand is that it's not that there's PDA and autism spectrum disorder, for example, because our focus is a little bit more on ASD, autism spectrum, this evening, but rather that PDA potentially may be a subtype of autism spectrum disorder, as you'll hear me talk about in the UK and Australia. But think about it that way for this evening, that PDA seems to be a profile that's associated with autism spectrum disorder, certainly not a separate diagnosis, and certainly not something that's diagnosed within autism. Just consider it as more of the profile right now. We know that individuals who present with this profile, PDA, share a lot of those characteristics. They present with a lot of those characteristics of the individual with autism, a lot of the social deficits, particularly the reciprocal conversation, the development of friendships, their ability to engage and communicate appropriately and in a functional manner. We see those restricted range of interests, repetitive kinds of behavior, and certainly the sensory issues. There's a much greater aversion to sensory stimuli, and that can also be more problematic at raising their arousal level. So individuals with PDA profile, again, commonly associated with autism spectrum disorder more than the other diagnoses, and we see a lot of the overlapping symptoms for individuals that have this profile. So what are some of the key characteristics for individuals with PDA? Extreme avoidance, as the name really describes it, pathological demand avoidance. So extreme avoidance of the everyday demands that are presented. And if we think about the kinds of demands throughout the day, whether it's a child or an adult, and we'll talk more about explicit and implicit, direct and indirect demands, whether it's wake up, get out of bed, have your breakfast, get dressed, go in the shower, brush your teeth, get your lunch, get your school bag, remember to get your wallet. These are the chores that need to be done around the house, or those that are inside our head, that there are a tremendous number of demands that can raise significantly our level of discomfort or arousal level, anxiety, and the tendency is to display extreme avoidance from those demands and expectations. And on top of that, even the anticipation that there may be some demands forthcoming could be enough for the individual to display that extreme avoidance. So we also understand that individuals with PDA have a highly sensitive nervous system. So our nervous systems are wired so that we're in a position that's going to be helpful for us for survival. Well, when that system is so highly sensitive, it may trigger a threat response that can contribute to that over response, that overreactivity for the individual. You see this.
I just want to check in with you. Are you advancing your slides? Because we're still just seeing the first slide.
Oh, is that right? I am. Let me try to restart and see what the issue is. Which one do you see now?
There's not, your slides are not showing now.
All right, let's see if I can get back to that. Let's see. My apologies.
Thanks for hanging in there with us.
All
Okay, that's the first slide.
right. What do we see now?
Just the first slide.
Still not advancing?
Correct. Not advancing.
All right. I'm gonna try something a little bit different here. I'm gonna exit out of my PowerPoint and see what that does for us. Should have the first one up, right?
Yep,
How about now?
still the first.
Not sure what to make of that. Are you able to grab my slides by any chance?
I have what you sent me separately. Should I see if I can share that?
Yeah, I wonder if and yours, when you stop sharing yours, right? I see some people trying to help us here. Yeah, if you want to try to share, I don't know if something happened when we switched from your sharing to mine, because we both saw that it worked beforehand, right?
Yeah. Just share. When I try to share, it gives me a message saying it will stop your screen sharing.
Okay, you want to go ahead and do that.
So let's see here. Oops.
And if you go to slideshow and click start, there we go. And then click where it says slideshow, play from start. Okay, let's go ahead and do that. And we can you click down? And I'll just say, I'll say okay when we go on to give you the enough to go to the next one.
Okay, so which slide should we be
On to the next one. And the next one. Perfect. Okay. Thanks, everybody. Teamwork here. So as you shared in the beginning, developing a curriculum on social problem solving, right? The key is whatever problem may present itself is to maintain composure, right? And that's what I try to model. And I think some teamwork allowed us to do that. So hopefully all the participants and those watching this on the recording, we've got some patience, and self-compassion is probably the best step toward showing compassion toward others. So I appreciate your patience and flexibility despite the best laid plans. So with this graphic here, what I want us to be able to look at is, and we'll start from the top, that when the individual perceives a loss of autonomy, a loss of where they have that independence, which is what all individuals are really seeking, whether they can verbalize that or not, that can really trigger that significant threat response. And we move around to the right of this image, that when someone feels that they're out of that balance, kind of trying to get to that homeostasis, whether it's a child, adolescent, or an adult, their attempt to try to get back to that balance, back to that control, even if it was an actual loss of that autonomy, but that perception, which is pretty significant. And we also know that many individuals with an autism spectrum disorder have what? A lot of difficulty with theory of mind, of perspective taking, putting themselves into somebody else's shoes. So if their perception is that I don't have that autonomy, that's going to be pretty significant. So that loss of that can contribute to it and impacts their nervous system. So internally, externally, kind of feel this push and this pull, which can contribute even greater to that level of anxiety. Sometimes they may use things like attempts to joke and be silly, attempts to have some control socially to exert that level of control, because when one feels a greater level of control, that increases their autonomy, at least their perception of autonomy, and then they feel like that they're in a safer and more comfortable environment versus feeling that level of threat. However, while they're presenting as more sociable, perhaps on the surface, and you might hear lots of extra chatter, you might hear lots of attempts to ask questions to control the environment or to dictate, to tell somebody what to do, the reality is that still those demands that are being placed on them are pretty significant, and they might escape, they might avoid, or there may be more of a toward move, and that's the fight versus the flight presentation we might see. All right, you can go on to the next one. So PDA was first described in the 1980s by Professor Elizabeth Newson. And really, when she described it back in the 80s from England, that it was describing this profile that we're talking about, and really that control tactic that was much more significant. While that term, which has been around for many years now, gosh, about 40 years or so, pathological demand avoidance, there have been some additional terms that have been presented, and I think some of those are a bit more compassionate, like extreme demand avoidance, rather than using the word pathological demand avoidance. The other one is persistent drive for autonomy, which is really a variation on the PDA specifically. Thus far, at least what we've seen in the UK and what we've seen in Australia, is using PDA, specifically pathological demand avoidance. Whether or not that term will be changed more formally to EDA, extreme demand avoidance, or the persistent drive for autonomy, remains to be seen. But just know that that's at least the short history there. Okay, next slide. We'll see in this graphic, while I won't go through each of the items, you'll see that sort of the field has come a long way over the last 35 years or so, or well, no, 45 years. This one takes you up till about 2015. So there's PDA Society that first started about 10 years ago. There's now a United States version of a Pathological Demand Avoidance Society. There are conferences now that are held, at least over the last several years. There's some excellent webinars and information sessions that you can access as well. So again, we've come a long way in terms of the formation of the background, the understanding, but not with a lot of research, which we'll talk about. Okay, next slide. So some of the key characteristics, I've mentioned a few. So again, significant avoidance, drive for control, weaknesses for sure in perspective taking, the nervous system pretty high. We've talked about that. The social emotional learning strategies, for sure, we see that the individuals who present with PDA have deficits in their social emotional learning, but their attempts socially to gain that control is again through what may be seen as manipulation and trying to change others' behavior. I want us to be very careful when we use the term manipulation, because joke intended here, when we think about as adults trying to change a child's behavior, we'll use terms like applied behavioral analysis, behavior modification, a behavior intervention plan. But when we say the child's trying to control our behavior, we call it manipulative, right? But we want to describe ourselves as manipulative. So I tend to not use that phrase myself to say that the individual is manipulating us, but rather they're trying to exert control. They're trying to change our behavior. And for them, it can be very purposeful, them meaning the individual who presents with PDA presentation. We also see the significant emotional dysregulation, where outside what they're experiencing, inside what they're experiencing is really making that individual have a lot of difficulty in being able to remain calm, have a heart rate and breathing at a comfortable place. And you're more inclined to see the emotional outbursts as a result of that. Consequently, we see a varying degree of cooperation from the individual. You'll hear me say several times this evening the phrase cooperation over compliance, because we really want to stress that it's not and shouldn't be about the adult trying to get the other adult or the adult trying to get the child to comply, to listen, but rather to focus more on cooperation. And if we can shift our mindset a bit more to try to gain cooperation, doesn't that suggest a bit more about us working together versus an adult trying to get someone else to listen to them, which in and of itself evokes a bit more of that resistance and some of that fight-flight response. Okay, next slide. So what else? We might see that the imagination and play, the creativity could be pretty significant on a positive side for the individual with PDA. However, while they may be inclined to engage in some role play, if they're perceiving that this is what I'm asking you to do, then that's yet another demand. Like, hey, let's go do some social skills training. And we know that social skills training, social emotional learning can be very beneficial for teaching new skills, the acquisition of those skills and modeling that. Again, that's a demand. Hey, let's go practice this. Come on over here. Again, a demand. So while the individual may be interested in some of that pretend, some of that fantasizing, some of that role play, we have to be really careful about how we're presenting it. If we can present it in a more cooperative manner, we're more likely to gain what? Cooperation. If we present it more in terms of, I need you to do this, then we may be seeing as an outcome of that, more of that resistance, more of that fight, flight, or freeze response from the individual. So being very careful about how we present something, that if we can do it together with cooperation, then more inclined to get a bit more success. Okay, next one. So we're also likely to see inconsistency in behavior. That's not uncommon. When we talk about individuals with behavior issues, we might say that the only thing that's consistent is the inconsistency in the presentation. For sure, we see for individuals with PDA, that same kind of theme, that you could see inconsistency in the presentation, that they may become overstimulated in one situation and understimulated in the same situation, or the same situation from one day to the next. Often described, while not the most pleasant of presentations, the Jekyll and Hyde, that I don't know where that came from. I'm surprised by that trigger. And part of it, again, we want to be cognizant of is that we don't know necessarily what the individual is perceiving. They may be anticipating a demand. They may be perceiving a demand even when it wasn't there. Your presence alone may evoke that. And it's why we're mindful sometimes when we say, well, hey, I don't understand what happened. We just came back from a long weekend. Or I'm not sure why they responded to that individual. They get along so well. But what was the experience just prior to that with somebody else? What was their experience last time with that person? What are they anticipating that person may do? Right? So just like a principal who calls someone's name, the principal may be the most compassionate, friendly, supportive, caring individual, but perhaps their experience before with being called to the office or the principal is going to speak to you had such a negative connotation that even though this principal who's incredibly compassionate, their presence alone may evoke that negative response. So we want to be really careful again about what are some of those early signs the individual may present with and communicate that among the team so that we're really mindful about that. Checking in with that individual, preparing them can be extremely important too. Okay, next slide. So what are the challenges? Pretty self-evident, but we'll touch on those for a moment. Educationally, certainly the behaviors can be highly disruptive to that individual's success academically, socially, emotionally, behaviorally, and can impact others in the educational environment. Socially, those challenges may impact that individual's ability to form and maintain friendships, which can continue throughout their life and into the workplace, into the community. Family. So the dynamics within the family can be impacted. There are lots of requests, expectations, need for cooperation, demands that are presented across individuals, whether child, adolescent, or adult. So that can contribute to the family dynamics, makes it a lot more difficult for the family to participate in family events in the house as well as out of the house. Okay, next slide. So we look at this as kind of a flow chart, how things may develop, how they may emerge. So a routine demand, please pick up your laundry. Please take a shower. Please, can you help me with emptying the dishwasher? Please, can we rake the leaves together? Please, can you give me a ride somewhere? Please do your homework, right? A routine demand. And it doesn't matter whether or not the demand is one which the individual can easily do or not. It's so much about the perspective. So keep that in mind. The perspective is incredibly important. If their perspective is that that makes me feel uncomfortable, that can evoke that increased level of anxiety or distress. It may also be for a future demand. Anticipating, again, as I mentioned, the principle could be that the parent walks into the room. So you're playing a video game, or you're watching TV, or you're doing work for your job and a partner comes over. Just the anticipation that that individual may be wanting me to do something, or just between your own ears, thinking about, I have a big meeting tomorrow. I have a big test tomorrow. I have a big sports event. I have a big recital. Or just, I've got a bunch of things to do. So the anticipation of future demands can evoke that anxiety, that discomfort, and could result in avoidance and escape behaviors. And I imagine we can all relate to that. Well, let me just put it off for another day. Oh, I don't want to think about that. I don't want to deal with that. And if we're functioning pretty well, that can be very workable. That can actually be helpful. Okay, well, I'm not going to do it today. Here's when I'll do it. I'll manage it. Yet we know if we continue to avoid and escape and delay, that's probably not very functional. And more so when we think about individuals with PDA, it tends to be the outbursts, the more noticeable behavioral presentation of that escape and avoidance. Could we see some withdrawn behavior? Absolutely. It's in response to either real or perceived demands, present or future demands that can really provoke that. And when the individual is experiencing that anxiety, their tendency to escape, to avoid, to fight, flight, freeze, that can reduce some anxiety. So as mentioned before, oh, I'll deal with it later. Went from a heightened level to, it's not right in front of me anymore. It's in a more manageable place for right now, right? Until someone brings it to my attention again, until I'm reminded by it myself or seeing a post-it note that, or my alarm or my calendar note reminds me, and then I'm right back in it again. And then I engage in some behavior, and then I'm right back. And you can see how this cycle develops. And what does one learn? One learns that, I can decrease or seemingly get rid of my discomfort very quickly by avoiding that demand or that perceived demand. Yet, how functional is that? Because if we keep moving away from that which is uncomfortable, we tend to then miss out on the things that are important, like tending to cutting the grass or cleaning up around the house or doing the laundry or completing homework or preparing for a meeting. So short-term relief, yet what we're experiencing is the impact of avoiding of important things. And particularly when we think about individuals who present with PDA, the impact can be even greater because it can impact relationships. It can impact one's overall emotional regulation. It can impact their performance in the workplace or educationally. Okay, next slide. So what are some of the factors? We've talked about anxiety, need for control, sensory sensitivities, and then there's also contingency management. Well, how could that contribute? Well, if you think about, hey guys, we're going to use the token system. So when they earn 5 tokens, then they can get a walk. They can earn an iPad. They can earn jumping on the trampoline. Or, hey, when you sell 10 of these widgets, then you can have this bonus, right? So you might say, well, they're incentive based. That's positive. Well, what's contained in that? What's contained in that is when you do this, then this will happen, which is a demand. So that demand again that's present, and as I mentioned earlier, it could be also your own perception. I want to get to this heightened level. So one's own anticipation about what they want to do and what they want to accomplish can also contribute to that significant discomfort associated with demands or perceived demands. So it doesn't mean we throw the baby out with the bathwater and we just forget about all incentives. We just have to be really mindful about how we incorporate contingency management, reinforcement systems, trying to gain the child or adult's cooperation, have a discussion about it, ensure that there's some choices in there. Make sure we're checking in with values. What does the person care about? Rather than someone else saying, this is what I will give you when you do this, which is much more focused on compliance. I need you to do this and then I'll give you that, versus through discussion to have a much greater understanding. Next slide. So we have hundreds of demands, right? And I alluded to that earlier, from the time you wake up to the time you go to sleep. Some of those are very explicit. Do this, or it's on paper, or somebody emails and makes the request. Some are a bit more indirect, so socially implied. Like when I meet you, I should shake your hand or wave, or we should make eye contact or exchange pleasantries if we see each other in the supermarket or see somebody in a hallway or in a classroom or in the workplace, right? Responding to somebody's smile, that's what I'm supposed to do, right? Or just body posturing in a social situation. So a bit more indirect. And then internally, that we have these demands or expectations that we wake up and we have the thought, well, I should get out of bed. I intend to work out, so that's what I should do. Oh gosh, I should finish that book. I've got some homework. Maybe I should do that. So nobody's asking me. Nobody indirectly is communicating that, but I'm mindful of that. And internally, I'm thinking about that. Uh, I should get dressed. I should move on. So I should eat better. I should eat healthier. I should get more sunlight. So those demands can range from a lot of different standpoints. So as adults working with or treating or advising, we want to be really aware of that it's not just what somebody is saying or implying, but it could also be one's perception. And when the individual has weaknesses or deficits in their communication skills, that makes it even harder to get a sense of what they're thinking and experiencing. Next slide. So we can just go ahead. We don't really need the sound for this, but just the prep for this is just to think about if we had a sense of what are some of the thoughts or feelings that individuals might be thinking when they're sitting in our classroom. This can also be relevant for adults. What are we noticing that's in our head in a workplace? So if you can just click that on. Yep. You can go to the next slide. Thanks. So what's difficult again is to know what's inside the individual's head. What we want to become better and better at as the adults working with the individual is to have an awareness that they could be uncomfortable and that their ability to communicate that discomfort is often a weakness. We know as adults, if you think about an individual, an adult who doesn't have social emotional learning deficits, we don't always communicate clearly and honestly how we feel. So if you're speaking with someone, you see them in the workplace or see a friend, family member at a get together, and you ask, how are you? They're not going to necessarily tell you all of what they're experiencing, all of the challenges that they have in their life. They're more likely to say, I'm good. How are you doing? Right? So while children sometimes will communicate through their behavior what they're experiencing, some children are pretty good at hiding that. Some adults are pretty good at hiding that. And when an individual presents with having a PDA profile, they have a much harder time communicating clearly and calmly in words what that may be that they're experiencing. So why are those demands a trigger? We've talked about that perspective of seeing that as a threat to them, moving them off of what their comfort zone is, throws them into perhaps a high alert, and it's just a real overload of their system. We can go to the next slide. So what may come out of the adult's mouth may seemingly be very clear. It could be very jumbled in the perspective of that receiving individual. Next slide. So what else do we have to be aware of is that we want to be careful about for ourselves that we don't want to go to our own survival response. So while our instincts may be good, we want to be careful that we're not trying to respond to the individual's threat or survival response by simply telling them, no, stop it. You need to calm down. Because think about how you'd feel if you have a heightened level of arousal and somebody tells you to calm down. We do better to try to help them, and maybe even if they have a heightened breath, be there with them where their breaths are, and then gradually model that, taking your breaths down and helping them to take their breaths down, validating, acknowledging where they are compassionately. And notice and think about that it's not that they're being oppositional. It's not they're trying to be defiant per se, but their system, again, is having a lot of difficulty. And the key bullet there at the bottom says that we want to work toward that greater cooperation to help that individual, and here's a key phrase, to be more happy, relaxed, and engaged. If you think about an individual, child through adult, when someone is happy, relaxed, and engaged, you're not going to typically see significant behavior issues. So learning how we can help that individual compassionately get to a place where they're more happy, relaxed, and engaged, we're much less likely to see the symptomology we're talking about. Okay, next slide. We hear the phrase and use the phrase going from 0 to 60 or 0 to 100. And that's really what happens sometimes, is that escalation can go from where they are happy, relaxed, and engaged, and then bam, they perceive this demand, or this demand is placed on them. And the adult may think that, gosh, this was just a pretty normal, reasonable demand. And then we go and we see that shutdown, anger, and panic. And one of the things I often say is that where there's anger, where there's strong emotion, there's almost always some emotion prior to that, which may be disappointment. It may be frustration, embarrassment, sadness, fear, worry, concern, right? But what we see is we see that the individual is in one place, and then they escalated significantly to this blow up, this tantrum, this angry outburst. We've got to be mindful that it actually had some sequence there, but we may have missed it and it jumped right to that red zone, because for that individual, that's what their MO has been, is that's their attempt to cope and try to have some control. Okay, next slide. So what would we expect if the person is not able to avoid, meaning the individual is trying to escape or avoid? You're going to see the things that we often see, unfortunately. We're going to see meltdowns. So if the individual is in a corner, or they're underneath a desk, or they want to be left alone in their workplace, and we're triggering and we're triggering and we're triggering, and they're attempting to escape and avoid, we may see that escalation. We may see significant social avoidance and anxiety, severe withdrawn behavior. We may see frequent conflicts. We may see angry, aggressive outbursts, significant resistance to change in routine, a great deal more rigidity, right? Significant degree of trying to exert control over all the stimuli in the environment. So you might be sitting here and saying, well, that describes a number of individuals with ADHD or autism spectrum disorder with whom I work, or my own child. And I'd say, right, that doesn't mean that PDA is this new profile that describes a child we've never seen before. What for me this has done over the last several years is it's an acknowledgement, oh yeah, that helps me to understand this individual a bit more. It sort of gives some validation that, oh, okay, it makes sense. Well, not every individual, for example, with autism has this presentation, but for those who present with this, well, it makes sense that there's a great deal of evoking of this response because of the heightened level of arousal, the heightened level of anxiety, discomfort they're experiencing. Your next slide. So what does it look like in the classroom? Acting out severely, hyperactivity, perhaps, screaming, arguing, fleeing. It could be school avoidance. It could be elopement from the classroom or from the building. Or it could be a bit more passive where they're daydreaming or closing their eyes, sleeping. Freezing may look like this numbness and sometimes even catatonic-like behavior, which could be something, of course, more significant. But the individual may feel unable or unnerved about even moving and acting and responding because of the heightened level of discomfort they're experiencing, feeling numb. Next slide. So we may also see a fawn response. So we talk about the fight, flight, and freeze. The fawn we may talk about a little bit less, but fawn is where the individual is really consistently over and over again, kind of abandoning their own assertion and self-advocacy, not avoiding conflict, or sorry, not avoiding the situation per se, and not aggressive toward, but they just sort of don't want to get into any conflict, and it's just kind of easier for me to just give up and do what you want me to do. We may see this a bit more with individuals who've experienced traumatic, have had traumatic experiences, and will sort of adhere to or, you know, be a bit more subservient to the individual rather than to engage in some conflict. Next slide. And not surprisingly, when we think in general about trauma responses, which is why we also describe PDA sometimes as potentially a profile for those who have PTSD, is that when someone has had trauma, experience of trauma, whether big T trauma or little t trauma, as we might say, that fighting, they might confront the threat, the person, the situation, avoiding, running away in terms of that flight response, freezing, really more dramatic and significant shutting down, or appeasing the threat, which sometimes we see in significant abuse, neglect, domestic violence kinds of situations. We might sometimes see that fawn response. Next slide. So this measure, to be clear, is not an assessment of PDA, or in this case, EDA. It just kind of enlightened us a little bit to some of the symptomology. So one would not take this measure and administer it to their child or to a client or to a student and say, well, they've met 7 out of 8 criteria, or 8 out of 8 criteria, 6 out of 8 criteria, so therefore they have PDA. It is not a diagnosis, but it helps us to understand a little bit more of some of the traits, and they've used this particular measure for some research purposes. But again, it's not a diagnostic instrument, because we're not coming away and saying the individual has PDA, but it really highlights some of those symptomology that we're describing. Perhaps next time I'm presenting, we'll have a questionnaire that aligns a bit more with a diagnosis, but I don't anticipate any time in the immediate future, meaning the next year or two, having it as a diagnosis, but we'll see what happens in the next version of the ICD and the DSM. After all, we think about Asperger's syndrome, for example. At some point, that was a profile before that became a diagnosis, and then no longer a diagnosis in the DSM. Next slide. So etiology, as I've mentioned, really most of the research, which is not a lot, has come from the UK. There are indications that this profile was present very early on for the individual developmentally. Overall, we have very limited research in the field, and very few peer-reviewed studies that tell us that, or tells us that there's just not a lot of information that can guide us thus far. We don't fully understand all of the causes, which that probably sounds familiar because we don't understand all of the causes for autism spectrum disorder. And whether or not there's something unique about it from a neurological standpoint, environmentally, genetically, we understand thus far there probably is, but nothing definitive that would guide us in terms of etiology. Next slide. So it's understood as a profile and really being understood, as I mentioned a couple of times, increasingly more in clinical practice in the UK and Australia. But given the number of individuals that we see, so parents, adults, educators asking about this, curious about PDA, we're doing a webinar here. I did several webinars over the last 4 or 5 months on this topic. I know some others that have presented on this. This is becoming more and more an area of interest. So I think it helps us to understand, have some greater appreciation for this profile. Next slide. So some of the research thus far has indicated that about a third or so of individuals with ASD may have these traits of PDA, but again, not very definitive. One of the things we want to be noting is that we don't think of that an individual with PDA has oppositional defiant disorder. I'm going to insert a bit of my personal/professional opinion here. We've got to be really careful when we talk about oppositional defiant disorder. So while that aptly describes a pattern of significant negative, oppositional, defiant, hostile behavior, it doesn't typically tell us a lot about, or anything about, etiology. It doesn't tell us why the individual is oppositional and defiant. And perhaps we might see over time, or at least where we are now, say maybe the individual having ADHD and ODD, or having autism spectrum disorder and ODD, maybe that doesn't bring us much more understanding. Maybe if we look at the individuals having autism spectrum disorder, and let's understand a bit more about the avoidance of demands that they're presenting with, and the anxiety that they're experiencing. Maybe that's a bit more helpful than giving another name of oppositional defiant disorder. It doesn't mean that we should avoid the diagnosis of ODD, just be very mindful about what is it adding for us to understand the individual. So just be really mindful about what are the current criteria and diagnoses we have, and what is the additive factor about giving. Sometimes I might see 4, 5, 6 different diagnoses for an individual, and it doesn't necessarily give us more information. Clinically, we want to be able to describe what we're seeing in the profile, and the more we can understand, the better. Next slide. And I'll probably move a little bit more quickly here, as I know we don't have a ton of time. I want to make sure I can get to more of intervention. So I've talked a little bit about ODD and PDA, so I think we can skip this slide. One of the key features there is really the emotional dysregulation that we want to be super mindful of, particularly for PDA. As I mentioned, a bit too early to talk about evidence-based strategies, yet what we can fall on or fall back to are, what are the interventions to help individuals present with significant anxiety? What are the interventions we know that are hallmarks for autism spectrum disorder? What are the strategies to help improve perspective taking and awareness and social interaction and communication skills? So perhaps in the future, we'll have better research that will guide us specifically to this profile that's emerging. But for now, we're going to need to look at what is the evidence-based research that helps to guide us for some of those other components, like I just mentioned. And we certainly, whatever it is that we're doing for intervention, we want to monitor progress, meaning we want to collect data on what are the demands that are, or what are the situations that are evoking that response. When does the behavior occur? What intervention are we using, and how is the individual responding to that? And then modify as appropriate. Next slide. So we want to really be able to have lots of flexibility. We know that for the individual, one of the challenges they have is rigidity. If we respond with a great deal of rigidity, that's not going to be likely very helpful. The more we can offer choices implicitly and explicitly, would you like to use this toothbrush or this toothbrush? Would you like to sit here to work or to work here? Do you want to work from home or you don't want to work in the office to an adult? Perhaps we give them some choices if we can. We can't always give that range of choices, but where we can work toward greater cooperation and choices, we're going to have a much more compassionate approach and less likely have the individual pushing back or escaping. Next slide. I would emphasize a lot of patience. So when we're being flexible and being patient, we can modify some of those demands. So a couple examples, instead of saying, you need to clean your bed, or you need to make your bed, you need to clean your floor, we might say, hey, there's clothes on your bed. I'm happy to help. And then maybe walk away for a moment. Or I wonder what we should do with the toys that are on the floor. Or, hey, we just finished dinner. All the dishes are there and utensils and cups. We're gonna have dinner again tomorrow. What do you think we should do? Right? Certainly, you might get a smart response from the individual. They might not want to help and cooperate, but we're being mindful of this because we want to evoke more cooperation rather than giving them yet another demand, right? And if we can give them choices, so we've got a bunch of things we need to do around the house. Gosh, that's a lot for me to do. I wish I had some help. Oh yeah, I'd love to help. Okay, well, these are all the different things. In what way do you think you could help me? Right? We're presenting it a bit more as a question. Is that an implied demand? It may be, but a lot better than a direct demand. Being careful about words like no, you can't do this, don't do that. Certainly in some cases where safety is an issue, we need to say no, we need to be firm. See where we can be more flexible might be helpful. Next slide. In the PowerPoint that you'll have access to, you'll see this as again as well of all of these slides. So there's an acronym PANDA. So pick our battles, work toward anxiety management, negotiation and collaboration. That doesn't mean we negotiate everything, but having that opportunity to be able to collaborate. Disguise and sort of manage the demands. We're not being deceitful, but again, being a bit more flexible in our presentation, as you just heard me say, with some ways to kind of soften it and be a bit more indirect. And try to adapt. Now, we can have some adaptation to what we're presenting, use some humor, but what we also know about many individuals with autism, ADHD, they may not understand humor. They may not get some of the parts of speech, the word usage that we have. So they may not realize that something is intended to be silly or funny. So we have to really be careful about when we're going to use humor, but certainly flexibility is really important in adapting. Next slide. Collaborative problem solving. So this is a huge one, is being able to work together. So the more we can align with, these are goals, this is what we both care about. We both want to be able to do something fun and it's pouring out. We both want to be able to go away on vacation, but we're kind of at odds here, right? So how can we work together and align towards some decision-making collaboratively versus I'm the adult, so you need to listen to me if we're talking about a child, or I'm the teacher, so therefore this happens. Well, one of my pet peeves is when we say you don't have a choice. The individual always has a choice. They could drop down to the floor, they could elope, they could aggress, they could do nothing. All of those are choices. So the more we can engage in some collaboration, some problem solving, exploring potential solutions, we're more likely to achieve some success and help that individual to regulate their emotions a lot better. Next slide. Emotional support. So much of that is validation. So as adults, we often think we need to help or make that individual feel better. A loss of a loved one, a loss of a job, a poor test score, not doing well in a sports event or in the theater. And we're thinking, I feel so badly for them. I want to make them feel better. And sometimes, sure, we could do that. But we're much more likely to be successful by acknowledging and offering that emotional support. I can imagine this must be really difficult for you. I'm really sorry that you're feeling this. I'm here for you. Please tell me what you're thinking, what you're feeling, right? Let me know whether you want to, when you want to hear some solutions. If you've had an extremely difficult day at work, right? Do you want someone to just say, here's what you should have done instead? No, you probably want some validation. And if and when you're ready to talk through some strategies, absolutely. Part of what we also want to help the individual is sometimes problem solving and validation may not be all of what we need, but maybe it's just some acceptance. I say just, but acceptance is pretty significant. And acceptance isn't, oh, I love this, I'm okay with this, but it's more a willingness to experience this discomfort. I don't have to like that. I think it was a wind chill of, I don't know, 10 or 5 degrees tomorrow. It's pretty darn cold out, right? And the wind doesn't help. And some people have lost power, I think, over the last day or two. I lost my internet, for half a day yesterday. I accept that. It doesn't mean I like it. I don't like that for whatever reason my PowerPoint didn't populate in the beginning. Fortunately, I had an out, right? I back up and it seems to be working. But the next moment's not guaranteed, right? So I accept that there was, kind of a flub there. And we talked about it before everybody got on. Sometimes there are technical issues. So we've got to back up, right? And even then, sometimes things don't work out as designed or as desired. So the acceptance doesn't mean that you have to like it, but it's not rejecting the reality, a willingness to experience that which is there, even if it's uncomfortable. That's a huge piece emotionally. If we can help that individual, it increases their flexibility, particularly as it relates to demands and expectations. Next slide. Recognize that a lot of what we see is only the tip of the iceberg. There's so much below that. And I alluded to that before. There's so many different emotions. There's so much between the ears, the chatter, some of which is helpful, some of which isn't, that can contribute to that which we see above that iceberg. Next slide. Think about that emotional regulation is not trying to change the individual's feelings. So keep that in mind. It's not about trying to soften it per se of, oh, don't worry. It's no big deal. This isn't something to be sad about. You shouldn't be angry. Again, how would you feel if someone told you that? What they're feeling is what they're feeling. We can help change their relationship to the demands, change their relationship to their sadness, change the relationship to the situation, right? I don't have to like the freezing cold. I don't have to like that if I hurt my foot. I don't have to like that my PowerPoint didn't start. But I can be flexible in experiencing that, hey, that didn't go as expected. That really stinks. I don't like that. And I can move forward even with that difficult emotion. That's really kind of the epitome of that acceptance and flexibility. Extremely difficult for many individuals with autism, with ADHD, certainly with trauma, certainly with this PDA profile that we're talking about. Next one. We can actually go to the next one. So I touched on most of that. So the goal really is not to help the individual to get rid of those uncomfortable feelings, but to be able to accept that. And it's why if you think about this little word and, how powerful that can be to promote that flexibility. How often have you been in meetings and somebody gives an idea and somebody says, yeah, that's a really good idea, but, right? They've heard it and then they're going to take it down with all the reasons why it can't happen. And what if our response to that was, hey, you just said the reasons why their idea couldn't work. What if we listen to what they just said as an idea, acknowledge, notice the concerns you have, and be willing to move forward with both? Let's explore that really good idea. Let's be mindful of the concerns or challenges that are going to get in the way and see how we might be able to overcome that, or accept that there's going to be some things that aren't going to go so great with that. Because that is the reality of life, isn't it? If you think about anything that's really been meaningful, important to you, there have been some challenges that have come along with that, discomfort that's come along with that. For the individual with a PDA profile, they're much more rigid with that, much more reluctant to be willing to experience that discomfort. So they push it away, or they move away, or they fight, or they freeze, right? I don't want that. I'm not willing to experience that. I don't even want that at all, or even potentially want that down the road. So I'm out of here. Or I'm going to fight you or fight this on it. How well does that work? pretty well in the moment, or at least they think it does, but not very sustainable. Next slide. So, yeah, next one. Here we go. So what are some alternatives? Walk away, take a break, short term. Exercise, talking it out, accessing help. Do something fun. Draw or write, get a drink. By the way, any and all of these can work well also short term. But if you do any of these to an extreme, isn't that escape and avoidance as well? So someone could exercise, but if you're exercising 3-4 hours a day, every day, and not doing what you need to do, that could be problematic. Taking a break continuously, problematic. Drawing, writing, reading, doing something fun continuously, but not attending to what you need to do otherwise, problematic. So we've got to be mindful about the strategies we use as well, because they could be helpful short-term, but perhaps not long-term. Next one. This feelings log, which I included, and there's a full version of this, it should be in the handout, is a nice way to kind of process with an individual, particularly a child or adolescent, what happened, where were you? Let's review the situation. And at the bottom, it says role play. Again, we have to be careful. We don't want to have another trigger for the individual, but it's a way that we can kind of process what just happened and help them to assess and check in about their emotions. Next slide. This activity I like to do either with individual children, small groups, an adult you could practice it with. We're going to review the particular situation. We're going to talk about it. We're going to role play it. We're going to practice. We're going to rehearse. I'm going to give you some feedback about what you could do, how you can handle it differently. You can get a pack of card of different situations, put them in a hat. If you're in a classroom, every child could have their own hat. In the family, every family member, including the parents, could have their own hat. We're just going to practice and review different trigger situations so we can talk it through and engage in some practice again. Next slide. In any situation, the more we can prep someone, coach them, prepare them, cue them, review, provide praise, prompt them through it, the more likely we are to be successful. So we're preparing, we're priming them, giving them feedback throughout, and then reviewing how well it went. Next slide. Here's another way of looking at it. Point out, prompt, practice, praise, the 4 Ps. Next. So what kind of environment? We want to have an environment that is predictable and safe, although we also want to be aware that not every environment is predictable and safe. So ultimately, the individual does need to experience that there are changes in the environment, but gradually we want to introduce demands. We want to help them first to kind of get to a calm place. So what I'm saying here is if you have an individual that's highly dysregulated, then it's really difficult for them to start to accept and experience those demands. But if we can gradually go from their comfort, happy, relaxed, and engaged place to impose some demands, to promote some cooperation, provide choices, we can start to help them to acclimate, to get attuned to some of those demands more at their pace versus when the adult wants them to do that. So it's just about going really kind of slow and respectful at where the individual is. Next one. Providing some sensory options as well can be real helpful, giving them a safe haven in the school, in the home. We all have our happy places, so trying to get back to that can be really helpful for self-regulation, checking in about emotions and what my options are as well. Next one. Also want to make sure that we're walking into the environment as the adult and maintaining our composure, keeping calm, not bringing our own response that could be significant, which could actually escalate it. Sometimes we're not aware of what our tone of voice might do, or how our emotions might be leaked out, which could actually be contributing to greater conflict in the situation. Next one. Thinking about what does the behavior tell us? The kids who need the most love will ask for it in the most unloving of ways. It's so true, isn't it? They're not going to necessarily walk in and say, this is what my experience was this morning. This is why I'm frustrated over the last year and a half. This is the trouble I had this weekend. We don't typically hear that and see that. Yet they may communicate through their behavior. Next. So we want to think about being on the same page, and more that our goals are aligned, that comes back to the collaborative problem solving, the more likely we are to be able to walk that path together rather than be combative or feel combative. Next. A bunch of sort of the adult characteristics we want to have, for sure, being empathic, identifying the strengths that are there, working toward relationships. So we know that with very young kids, or any child who's coming to a new environment, that pairing, rapport building is incredibly important. We need to establish that rapport first before we start to ask of that individual to do things. So establishing that relationship, establishing that trust, providing reinforcement, praise can go a long way before we start to make requests. And also being really careful about judging. So one of the great characteristics of a good therapist is that they're non-judgmental, and that you can open up and you can share anything without the fear or concern that you're going to be judged. So that's also super important. Next one. When our little people are overwhelmed by big emotions, it's our job to share our calm, not join the chaos. So it speaks again to our own behavior, and whether we want to say little or big people, right? Regardless of the situation, share our calm, model our calm. Don't contribute to the chaos that's there. Next one. There's some bullet points here of how we might de-escalate a confrontation. This would, go well for parent-child, child-to-child, adult to adult, one country to another country, right? We could take this anywhere. How can we try to avoid confrontations? Good, solid communication, empathy, understanding, turn-taking, using language that's going to be helpful and collaborative. Next one. Educationally, we can incorporate into a 504 plan or an IEP specific understanding, talking about the traits or characteristics with which the individual presents. We don't need to, nor should we, talk about a PDA profile because there's not the evidence base for that. But we can talk about how the individual responds to demands or perceived demands. We can talk about their increased arousal level if we understand that, particularly if we have some input from a medical specialist. We could, or maybe an occupational therapist can give us some guidance as well in terms of their sensory response. We can incorporate into a behavioral intervention plan some specific strategies and a protocol to provide intervention proactively, as well as when the behavior starts to have its onset. And we can incorporate, where it makes sense, engaging that individual and providing reinforcement where and when it's appropriate, together with choices. I'm mindful that we're going to get to questions and comments in just a minute or two, so we'll go through the remaining slides a bit more quickly here in the last minute or two. The next slide. And we can go on to the next one. And the next one, I'll just kind of speak to behavior interventions. So when we're looking at behavioral interventions, what I've really captured in these several slides here is we want to identify what we call replacement behaviors. What are the skills we want to try to teach? In a very compassionate way, we want to be careful that sometimes that direct teaching, as I mentioned earlier, can be a trigger for the individual. So how can we cooperatively? Sometimes we may do this through play. Sometimes we may tap into what is motivating for the child. Sometimes even using video modeling. We may watch a video of how individuals are displaying the desired behavior. Or we could watch a movie and pause it and talk about the characters in the story. What are they thinking or feeling? We could be sitting at a park and watching the squirrels or the birds flying or running around and talk about the relationship. What are they doing? How are they responding? That could be a bit more indirectly of kind of processing some of the emotional piece. But we want to make sure that we identify what are the roles of the adults in the school building, if we're talking about educational supports, or in the workplace. What are the roles of the employer, or what are the role of the support personnel in that person's life? How are they going to support them in a compassionate way? Next slide. Make sure we're really clear about what the expectations are and how they might change for the individual, and really stressing the importance of giving that individual some downtime, some recovery time, and the opportunity to reset and to check in about their emotions. Next one. For families, we want to make sure that we can present also consistently. We want to make sure we're raising awareness. If you're on the educator side or mental health professional, what can we share with families? For families, make sure that we share with educators. What have you learned about this profile? And provide this and say, can we talk a little bit more about my child? I think I have a little more insight and I want to be able to share this with the team so that we can be careful about the intervention plan. What do we need to do when we're out in the community? What guidance do we need? Maybe bring that to the attention of your mental health professional. And maybe they're not as informed about this, or maybe they're not thinking about that for your child, and engaging with them to get some of their guidance as well. Next slide. So we've talked a bit about this, but just to be mindful that when we think about trauma, there can be specific traumatic event. There could be the history of trauma historically. There could be chronic trauma, which could occur when there are long-term health issues or community-based violence, just chronic emotional, physical, sexual abuse they may be experiencing. That can also really contribute. So next slide here. We want to be really mindful about that when one experiences trauma, that can impact their feeling, their mood, their emotions, their sense of helplessness and hopelessness, which can contribute to depression. It can really make them much more vulnerable, which can also contribute to the profile that we've been talking about. So next slide. So really be mindful about how we, in our behavior and our response, how that makes someone feel. It's a lot more important that how we make people feel versus the words that we say, as Maya Angelou shares with us. Okay, next one. So we have got to be careful about fostering social emotional learning, really incorporating that, if not directly, certainly infusing that in an educational environment, integrating that as best we can into the culture of the school, making sure that we're really mindful about helping the individual to feel safe and comfortable, because when one feels that their safety is threatened, emotionally or physically, they may be much more prone to display the extreme avoidance of demands and from individuals in that environment. And next. And we just want to also be really careful about the adults who are providing that support and that care and that treatment. We've got to care for ourselves. We want to be mindful of what's called compassion fatigue, that we give so much to others that we can experience that burnout and fatigue ourselves. So we want to make sure we're collaborating, we're spreading sort of that wealth of support in that community to support that individual. Next. So systematically, so providing that social emotional learning support, having that culture and climate, particularly if we're talking about a school environment, spreading that across the family, the community, and again, in the workplace that we talked about. Next. And next one. So if you're familiar with CASEL, which is also on the New Jersey Department of Ed's website, the collaborative for social emotional learning, you can see from the community all the way down to the individual, and the individual out to the classroom, the school, family, community, that across the board, we need to have that collaborative approach that really supports individuals like we're talking about this evening. Next. Just about there. So we're not going to go through these vignettes, but you might find this as sort of a turnkey, whether you're in a school or as a family, to process with your mental health professional or with the school or in the workplace. I have some vignettes here that go from child through adult, which you may find very helpful in seeing some examples of PDA. So you can skip through the vignettes here, and we're just about finished. So just before we get to the Q&A, I just want you to pause for a moment and think about, after learning about some of the key components of the PDA profile, as well as some of the interventions that we can consider, what is one thing that you could specifically do, whether it's for a child who may be in your home presenting with this, or an adult in your home, or someone you know in the school environment? What could you do that might make a meaningful difference? Is it turnkeying some of this information, sharing with others? Is it educating somebody who is in the classroom working with the child about how to be more compassionate in our approach, changing some of the language we use instead of so many direct requests, perhaps be a bit more collaborative and cooperative in the way we're presenting it. So what will you do? When will you do that? And really schedule that task so it can make a meaningful difference after this webinar. Okay, and the next slide. So we're a couple minutes beyond where I'd want to be, but we still have, I guess, about 10 minutes. At the end, you'll see that there are references, resources that might be helpful, and everybody will get a copy of that. But I think we could stop. We could stop the sharing and open it up for whatever Q&A. So thanks everybody for staying on, and look forward to seeing some of the questions you have.
Okay.
And for your patience with our snafu in the beginning.
Okay, we have lots of thanks. All right, let's see. First question, let's see. Have you experienced those with the PDA profile characteristics exhibited significantly more at home and not so much at school?
It's an interesting question. So professionally, I would say I can't give you a number or percentage. We in our practice work with many, many families, and many families see this type of presentation in the home. Work with many, many schools, and they see this presentation in school. What's interesting, and we know this for many, many years with an oppositional defiant disorder presentation, that sometimes the individual will present with that in the home, but not at school but not at home, and sometimes in both settings. And I would say the same thing here as we're talking about the PDA profile. And again, hopefully you're getting the sense, as I've been talking this evening, that I think the understanding of the presentation is more important than what we call it. So the presentation of significant avoidance of demands, direct or indirect demands, through fight-like behavior or fleeing, escape, avoidance, or freezing, we see this across all environments. So I wouldn't say necessarily that we see this more in one than others. I see that question about, yeah. So what's your advice to encourage acceptance for an individual with a history, of trauma, and make sure I get the whole question there. Yeah, trauma and ADHD that is very anxious about circumstances that happen unexpectedly. First of all, a lot of empathy, myself for that, and I think anybody that's working with that individual, because big breath here, because again, acceptance never means that I'm okay with it. It never means like, yeah, no worries, right? So when one has experienced significant trauma, significant events in their life, it doesn't mean that working through it means that they're okay with it. It means that they develop a willingness to be able to carry that with them in a way that's going to be manageable and workable. And unfortunately, life comes with lots of unpredictable nature to it. So we don't know when or how or whatever life's going to throw us, whether we've seen this for health reasons, we've seen this with the weather, we see this with wars in this world. So we just don't know what's going to come. And that makes it even more problematic, doesn't it? And that it becomes a lot more unnerving, because one of the biggest concerns, I mean, obviously there's the real impact that can happen, but there's the unnerving aspect of a loss of control. And whether it was 9/11 or we hear about these plane crashes, or again, war, weather events, there's an extreme lack of control. And when there's a lack of control, there's often significant anxiety, because then we don't know what to expect and we don't know how it's going to affect us. And what I often encourage and mindful of myself is, what can I have what choices do I have? What can I control amidst this unpredictable world? What choices can I make that can help for my own self-care, my own self-compassion amidst all of the seemingly chaos? I could choose in this moment to go do this. I could reach out to a loved one. I could do a caring act. I could do something for my own well-being, right? Maybe I can contribute to this bigger situation, perhaps. But I think it's When one feels paralyzed is often where they feel a lack of control and an increased level of anxiety. So we look to see how we can join with them to help them to feel a greater sense of options that they have. Not necessarily control, but some sense of control can come through knowing that you have some choices.
See the next, another participant thanking you. And she says, my son was diagnosed with anxiety, ADHD, and DMDD. How would you compare the PDA profile to DMDD?
It's a good question. So I'm not sure that we have enough information to say, how does this compare to this? I think someone that has a disruptive mood dysregulation disorder, think about that language there, that their mood is significantly dysregulated. They have a lot of difficulty managing and regulating their presentation. It might be interesting. Might we see that PDA is going to fall more under DMDD? Are we going to talk about a lot more of comorbidity of some of those symptomology there? I think the key factors are that the emotional dysregulation is certainly what's paramount when we talk about the PDA profile. And I think we would say the same for DMDD as well.
Participants, more of a statement. My son does not want to do anything. BCBA would not, let's say, would not leave till he complied to the demand. Always asked us not to prompt him. It never helped him.
Well, I can't speak for the BCBA's goal, or speak to the BCBA's goal in as you wrote, that the BCBA wouldn't leave until the individual complied. Without knowing anything more, I would say that wouldn't be the approach that I would use or recommend, because that sounds like that's kind of promoting more of a power struggle, and is going to have the individual be more inclined to escape or avoid, fight or flight from that situation. And I would prefer much more that we're going to cooperate here and work towards cooperation over compliance. As you heard me say, if it was a dangerous situation, I need for you to leave. You need to listen. That's a lot different, right? Somebody's standing in the middle of the street and cars are coming. We need to get that person out of there for safety. But I don't think that's what was, described there. So I think if you're continuing to work with that BCBA, I would say, can we talk about that what we've been doing hasn't been working, right? And it's not a comment necessarily on, hey, trying to get my child to listen. That's just the wrong strategy. I would focus more on, it seems like it's not helping my child, and my child is getting more agitated and more anxious. What if we were to step back and look at trying to get some more cooperation from my child? How can we find out what my child wants, right? Because it sounds like this professional is trying to get what they want. But I don't know all the story there. So I would really want to step back and look at what are everybody's goals here. And ideally they would be aligned so that we can have a strategy that's going to be aligned as well.
Such excellent advice. Let's see, does anybody else have any other questions? Thank you for your valuable advice. See anything else coming up? Well, okay. Well, I would say thank you so much, Dr. Selbst, for this incredibly informative presentation. Thank you, everyone else, for your patience and for joining us this evening. If you need further assistance, please feel free to reach out to us at the Alliance. The recording and the PowerPoint will be on the website. You can find us at specialeducationalliancenj.org. And enjoy the rest of your evening.
Thanks, everybody. Have a great night.
Thank you.